Ladies and gentlemen, please welcome Rachael Baitel, Chief of Staff, Russell Street Ventures, Michael Hall, Senior Advisor, Strategic Philanthropy International Medical Corps, and Felicia Knaul, Director of the Institute for Advanced Study of the Americas, University of Miami.
Thank you very much. I can tell that we still have a few people enjoying lunch, which is great. Buenas tardes, good afternoon, everyone. I'm very honored to be here with a very distinguished set of panelists, Michael Hall and Dr. Felicia Knaul, who's one of our hosts for the conference this year. So I'm just gonna go ahead and dive straight in. As you guys know, Concordia is kind of centered on building partnerships. And so in the vein of that, I'd love to kick it off by asking you both a question. So how do you think, in what ways can cross-sector partnerships really increase access to healthcare, especially for communities that are impacted by adversity in Latin America?
Thank you so much for that question. And thank you to Concordia for having me here. International Medical Corps has been a strong partner of Concordia for a while, and it's just a wonderful organization to participate in this way is just great. You know, when preparing for this panel, I had a couple of my colleagues, and our Chief Advancement Officer, Rebecca Milner, right off the bat said, well, you can't really accomplish anything these days without partnerships. And if you look at our organization from the top to the bottom, we are steeped in partnerships. Like you think HR, right? How is HR going to have a partnership? Well, we maintain a volunteer roster of a few hundred medical professionals that we can deploy at a moment's notice. And we have to work with health systems in order to maintain that roster that, again, our HR department maintains. So right there, you know, there's a partner. We have a partnership with FedEx, right? They store our stuff in Memphis, and whenever there's a disaster, they can deliver materials anywhere in the world for us in a moment's notice. Our partnerships also include local ministries of health, right? We would never enter into a country without working directly hand in glove with not only the medical establishment that's there, the hospitals, the clinics, the people, but also the local community and the Ministry of Health, so that we are providing a solution that's their solution. It's not our solution, it's their solution. And so we have to partner with them on that level as well. And then there's Concordia, right? And there's the U.S. Chamber of Commerce, and there's other convening organizations. And to the group out here, we're open for more partnerships. So if you think we're a group that you'd be interested in working with, please come find me. I'd love to have that conversation.
Excellent. Dr. Knaul?
So yeah, let me also echo our thanks on behalf of the whole University of Miami and of course our Institute for Advanced Study of the Americas to be able to host you here, to be partnering with Concordia. And you know, there's someone I really do want to give a particular shout out to Frances Davis, because she really did an incredible amount of work in making this possible on behalf of the University of Miami. So speaking about partnerships, I really want to think about that in the context of health systems in Latin America and, of course, post-pandemic. And one thing, and I completely agree with everything you put forward, Mike, is we need to recall the word patience. Our greatest partners, and I say this as a patient advocate, as someone who lived breast cancer in Latin America, is that we need to make sure we have that patient voice. If you don't have that, you don't really have a feeling for what's being required. Now, thinking institutionally, I think one thing we absolutely learned is the importance of intersectoral partnerships. That countries across the region, some, not all, a few exceptions, sadly Mexico is one of the exceptions, was to remember that you can work through anti-poverty programs and use those as platforms to be able to strengthen health systems and to be able to provide an effective delivery of services to the poor. But most of those being anti-poverty programs are intersectoral. They work through health, education, nutrition, women's empowerment, et cetera. But the other is to think for a minute on public-private partnerships. We've been speaking, I think, in Latin America for a long time about the reasons why we need public financing to guarantee financial protection, but we need what we call plurality, competition on the delivery side. So you can choose your doctor, but you know that you have financial protection in getting there. And then finally, thinking, again, post-pandemic, we saw an incredible leapfrogging in telemedicine and the use of innovation. It would have taken decades to get insurance companies to cover telemedicine the way that they're now really primed to be able to do. And so I think that is a huge area of collaboration for the future that we need to keep pushing forward. And going back to the patient, because that means that the patient doesn't have to travel, which is so difficult and painful for so many.
Yeah. Michael, you mentioned something in your remarks regarding healthcare workers. And so I have a question for you regarding that. How can Latin America prioritize medical training, especially considering our current economic conditions in the region?
That is the million-dollar question, in my opinion. I think the health worker shortage globally is the question for this group and for the health community that we have to tackle. The World Health Organization, I'm talking globally, estimates a worker shortage of about 18 million people by 2030. And what is this? This is challenges and opportunities in healthcare, right? Okay, so we got two numbers we can work there with. Right? So the first one is 18 million. That's the challenge, right? If we don't fix that problem, we are going to have lower worker productivity, and we're going to have a massive increase in misery, right? But the opportunity is in at 2030. How far below 18 million can we get by 2030? And I think there's a bunch of levers we can pull to help get that number far, far lower and help out the world so much more. And I think first we have to look at, well, there's some things that are intractable, right? I mean, like the aging population in Latin America, that's going to be a burden, right? That we have to deal with. But I think telemedicine is such a great thing that you brought up. The explosion of it, especially in Latin America, cannot be just passed over. I think that if we make those investments now, they will pay off by 2030. I think that it allows the medical professionals that we do have to reach more patients. So it increases the efficiency of those that are there now. Another way to do that is with community health workers. And this I'm going to talk about because of International Medical Corps. We might be one of the largest trainers of community health workers out there. It is an enormous part of what we do. When we go into a country, we want to have them be their own best first responders. So we start training people immediately. And what we found is, you've got your clinical staff, you've got your nurses, you've got your doctors, physician assistants, whatever. We need to have them keep that expertise in the clinic and not have them do non-clinical work that can be done by community health workers. I think that we need to have a real push to increase the number of community health workers that we're training. I also think, Latin America is going to have to deal more with technology and the cost of technology, controlling drug prices. I think that we're going to have a big push there. Yeah, I guess that's enough.
Dr. Knaul?
Please. So it's amazing that you started out thinking about shortages, because I really do want to say something about the gender composition of the health workforce, both paid and unpaid. The research that we have done shows that the vast majority of healthcare, paid and unpaid, is produced by women. But they are underpaid, exploited, unrecognized, uncounted. And the irony there and the tragedy is that what we end up with is particularly poor people in Latin America and all over the world without access to care, and then those who have been in fact trained to be able to provide those care without employment. That's on the paid side. On the unpaid care side, what we've seen with the pandemic is how incredibly important it is to provide caring. You said that aging is a challenge. It's also a huge opportunity, and it tells us that we need to think about training for caregiving of those who are older as well. A tremendous aging workforce and a tremendous aging population in ways that it took 2 centuries for Europe to do, and in the countries we work in, maybe 4 decades. Mm-hmm. But we can approach that change as an opportunity by effectively and in a dignified and gender equitable way, making use of this incredibly underutilized potential that we have. And I want to say just briefly something about community health workers. I entirely agree with you that this is a huge opportunity. But part of the reason it's being seen as an opportunity is because these are unpaid or underpaid women. Mm-hmm. Right? That's what makes it so cheap. That's what also makes packages of care so cheap, and that's the wrong way to approach it. It's in valuing those community health workers and what they can do. Last point is linking that back to the technology. This is only going to work if we think about the connectivity gap, because we need the patients and the providers at the primary, at the community level of care, to be able to connect to other providers. So we've got to close the connectivity gap, and we've got to think in our training about training a health workforce and a caregiving workforce that are comfortable with the technology of communication.
Both of your comments touched on a really important topic when we talk about healthcare challenges and opportunities in Latin America, and that's health equity.
Yeah.
And in our previous conversation, just behind the stage, we talked a little bit about how really the pandemic in Latin America can be compared to a tale of two cities. So Michael, tell us a little bit more about that, and tell us about kind of how we can protect the agency of the patient while at the same time really protecting those cultural differences that we experience in Latin America.
It's such an important question. And you know, it's not just Latin America, right? There were two pandemics, and I think we all know this by now, that we experienced, right? There was a one experienced by people of color and people of limited means, and the one experienced by everybody else. And we all knew that there was this health equity problem. We all knew it, but I don't think we ever had it thrown in our face like we did during the pandemic when you know, the numbers are just so stark at the outcomes of people who had COVID. And so, you know, yeah, I think now is the time to use that as an opportunity to capitalize on that and say we've got to do more about health equity. I think humanity is stuck until we really bring up the poorest of the poor people and move forward as a humanity. I think with the pandemic, as we know, a lot of problems in health systems became exacerbated. You had a health system that was underfunded, and now, you know, they bring in these COVID patients on top of that, and so people who had regular chronic care problems weren't going in because they were afraid to, or there wasn't enough staff to deal with that. Immunizations fell by the wayside. So what happened is it made the problem actually worse now, right? We have a sicker population in a lot of these places, and so I think we have to recognize the fact that, you know, going forward. Let's look in the U.S. It happened in the U.S. too. In poor areas of Los Angeles, New York, Nashville, Miami, right? We saw the same thing here. And what we find is that it shoots ourselves in the foot, because those people are going to need care, and it's just going to be far more expensive once they actually get the care they need than if we'll plug them into a system that the wealthy people experience, and they can stay healthy their whole life. Really quickly, an example, we started a new pilot program in Los Angeles where we're trying to bring medicine to the people who there's no other way that they're going to receive medicine unless we bring it directly to them, right? Think about a homeless person who can't leave their stuff, right? They're not going to go to the doctor no matter how sick they feel until they have no shot but to be rushed to the emergency room, right? So we have interest from hospitals in this program because, you know, they want us to be successful with this, even though we're kind of competing with them, because they don't want these people showing up and not being able to pay their bills in the emergency room. So we're pushing out to them to keep them healthy, and at the same time, we might actually alleviate the homeless problem a little bit in the process.
That's excellent. Dr. Knaul, Felicia, on that same note, how did the pandemic really exacerbate structural barriers within Latin America? And can you tell us about kind of what that means for new reforms and how we're thinking about getting out of this pandemic eventually?
So picking up a little bit on what Mike was saying, and thinking about this in the context of a particular disease and particular individuals. Like, we knew before that if you take breast cancer as an example, about 2/3 of women were being diagnosed very late in the game. And the numbers here are more like 10 to 20%, here being in the United States or Canada. So we already knew that. And we knew that the vast majority of that late detection was happening to poor women in poor, marginalized municipalities around Latin America. What happened with the pandemic, exactly as Mike said, was that they couldn't get even the screening they were getting in the beginning. What happened with diabetes is they couldn't get any of the basic care they were getting even in the beginning. So what we're going to see is what we're calling a tsunami of non-communicable diseases. But what this I think we have to highlight is that we tend to think that poor people have only suffered communicable diseases, right? It's not true. Poor people suffer more communicable diseases and non-communicable chronic diseases and injuries. So we knew that was the problem from the beginning, right? Now, what are the kinds of solutions? We also knew some of this, but I want to again highlight that point about the opportunity of our anti-poverty programs, of things like the cash transfer programs, the one that we had in Mexico until recently, that targeted and reached the vast majority of poor families, beginning with women and beginning with children. And that we can apply what we've been calling a diagonal approach. This is work that was put together by Julio Frank and Jaime Sepulveda. You'll hear from Dr. Frank in a little while on this. But a diagonal approach, what it seeks to do is think not only disease-specific or horizontally around systems, but how can you bring things together to think about synergies? And that's where those, I think, platforms come in. And the fact that some countries, and there's some amazing research by someone who used to be here at the University of Miami, who's now teaching and managing an institute in Germany, Marike Blofield, about how some countries in the region really expanded and harnessed those, what were cash transfer programs, to get cash to families during the pandemic, but also to get health care. And that's that last point, because a poor family that's offered health care is still poor. So if they have to trade in children going to school, trade in being able to feed their family in order to pay for that health care, you devastate them anyway. You've got to think about something that provides them in a dignified way with all of the aspects that allow them to manage the determinants of poverty and the determinants of ill health as a package. And finally, that we had some incredible health reform information. We had some proven, some evaluated health reforms in the region. I had the incredible opportunity of working on the Ley 100 in Colombia, President Uribe, going back a couple of decades now when he was a senator, and then in Mexico in the Seguro Popular. And we had, I think, really figured out how to allow people to get financial protection to tertiary level care as well as primary care. And the question is, what's happened to that? How can we continue to move forward on those reforms to get to a point where we don't have the medical apartheid?
Yep. Yeah, and you know, I should have mentioned when we were talking about economics, targeting these pre-existing conditions of hypertension and diabetes and whatnot has got to be a part of any solution. And frankly, it's where the community health workers come into it too, because they're perfect for pushing out into the community. You can't just sit around and wait for the person with hypertension to come to the hospital. You've got to go and find them and make sure that they're getting their care. Otherwise, they're going to cost you way more down the road.
Based on what you've said, it seems like COVID has kind of launched this momentum. And I'm curious, you know, from your perspective, Michael, how can this momentum be translated into perhaps a roadmap for long-term recovery?
So, you know, International Medical Corps, for those of you who don't know, we are a first responder. We will go in for acute situations, but we never think about it that way. We want long-term recovery. Let's look at the tornadoes in the Midwest. We are just now finding out that certain health facilities are overstretched because people who used to live here now live here, and the health infrastructure can't handle that. And so when we think about recovery, I know it's in the headlines for a few weeks, maybe a couple months, but really we're talking years. And you have to go into any sort of a situation, whether it's a disease outbreak like COVID or Ebola or whatnot, or a conflict or a hurricane. You've got to bring the community in right off the bat. You've got to chart that course together, you know, and I know we talked about culture a little bit. Culture is just not an issue for International Medical Corps, because I know they say, oh, we bring people in, give them a seat at the table. They are the table with us. We are there to support their recovery, how they want to chart it, and in the future. It's the only way to go.
Dr. Knaul, you mentioned to me how certain countries in Latin America put on pause some of their structural reforms, whereas others kind of really continued that momentum. How would you say the two can really build off of each other going forward for the region?
So I think one of the key areas is to think much better and more deeply about higher education and professional training. And so we've seen a couple of issues. One, I think, is really thinking about, again, the use of technology of communication and what it means to do a combined kind of training where you're trained as a professional in health, but you're also trained to be very comfortable in using technology in delivering that. So that's one. The other, I really want to push back and go back to the issue of gender, even though I know it's not exactly what you were asking me, but I can't resist, just to say that one thing we saw with the pandemic, of course, was women shouldering the burden at the front lines, both as providers of paid care, and again in their homes. But we went back and did some research on Latin America that we published recently in The Lancet. And there's a tremendous mismatch between gender in terms of the providers of care and leadership. And leadership of health education in particular. So we found that basically less than 20% of university presidents where their medical schools are women, and less than a third of deans of medical schools are women. So they can't really be effective in making tremendous use out of this huge opportunity that we have to move the system forward. And I know you were asking me more about how to bring those structural pieces together, but I just couldn't resist the gender card. And so I wanted to make sure I got that in, because I do think it's key to think about ways you can sort of push in a trigger that can generate reform. But the other is that I'm a strong believer in what we might call an economics of hope. That a kind of chaos and loss and tragedy that we've seen in our region is one that can spur us to be able to do the tough kinds of reforms that are required, to do something about the medical apartheid that is frankly also about the segmentation based on where you work. So the travesty and the sort of ridiculousness about deciding that your access to health care is determined by whether or not you have a salaried job is something that as a Canadian is incredibly foreign to me. Yet that's sort of the standard here and in many other countries. And that's what I think requires huge institutional change that might be able to come out of the kind of chaos that we're seeing, and particularly if we make use of, I think, sub-national policy making. So what can we do at the state level, at the provincial level?
Well, thank you both for your comments. I think we can all agree this is just the beginning, and there's so much to unpack here. But appreciate your time, and thank you all for listening.
Thank you.